who's joining us. And Dr. Stein is going to talk a little bit about the modeling and other things we're working with MIT. But before I go there, I want to go through some of the patients we're caring for, the number of patients and details. So today, Hartford Healthcare, an acute facility, has 137 patients. We have 3 patients in Bacchus Hospital. Charlotte Hungerford has 4 patients. And mind you, Charlotte Hungerford had more than 20 patients not too long ago. Hartford Hospital has 58 patients. Midstate Medical Center has 10 patients. St. Vincent has 43 patients. Hospital Center Connecticut has 16 patients. And Wyndham Hospital has 3 patients. 137 patients compared to 420 we had just about in mid-April is a significant decline in number of patients we have, which is a positive sign. It's a good sign that our hospitals have additional capacity to take care of the patients who really deserve non-COVID type illness. And we are seeing our patients who are looking for some more care coming back to the hospital. And we've done a wonderful job to make sure that the patients are safely managed. We've got different types of measures we've talked about before, our precautions and focus on safety and infection control, and making sure our operation is managed in such a way that we provide the safest and the best possible care to the patients who has been putting off their clinical issues for some time, and they're coming back to the hospital. As we look into where we are in Connecticut and our country, obviously our fight for the pandemic is still ongoing. It's going to continue for some time. We're going to continue to watch it very carefully. But one of the elements of our process to reopen our economy, reopen our hospitals, reopen up our system is a testing. And Hartford Healthcare has really taken this to the next level, in my opinion. We began our mobile testing to reach out to the areas where access to the testing is difficult, especially the shelters and nursing homes and churches and other areas where there's underserved and privileged community actually was unable to get the access, and we've created the mobile testing. We started in late April, and I'm so proud to say that right now we have 40 mobile testing sites across the state of Connecticut with 9 permanent sites. We're one of the largest largest testing capability in the state right now, supporting the need at the moment. And testing is one component of our process of reopening, along with contact tracing and social distance or physical distancing and many other things. But testing is critical, especially to understand how's our population doing and where we are and who can get the testing and get isolated appropriately. We started, as I mentioned, our mobile testing in beginning in April. Today, so far, Hartford Healthcare has done 43,000 testing on 37,000 individuals so far. We've had over 2,500 mobile testing done. That's a remarkable number for a healthcare institution to pull this off in such a short time. We've had 26,000 drive-thrus. We will be conducting 14 mobile site testing only this week. This access to the community, and we are privileged to be able to provide that and support the need at this time. We continue to have good capacity to do the testing. We are in a much better place right now than we were before. And thanks to our partnership with Quest, and thanks to the focus the Hartford Healthcare leadership has had to work with Quest to be able to allow that large-scale testing to be real in this place. With that said, just a few other metrics. We continue to use remdesivir. We have supply for more than 200 patients right now in our system, which positions us very well. We continue to use the convalescent plasma. We've got about 490 patients actually have benefited with convalescent plasma in Hartford Healthcare. And we're going to continue to have this medications and other details in our toolbox. We continue to have a good supply of PPE. So Hartford Healthcare is in well positioned right now to see what comes over the next several weeks to months to come by. And to decide what is going to come by, we've been fortunate to be able to partner with our MIT colleagues. Hartford Healthcare has had this long partnership with really the elite and the premier institution in the country. And we're so proud to have our professors such as Dimitri and many others. Dimitri has been a true partner to us. He has really advised us and worked with us and really predicted and created the modeling working with our clinical teams to really help us navigate this. And we're looking forward to this partnership in many other areas. Now, the role of Dimitris, with his all the analytical background, his several tens of research scientists and data scientists, they've been working with Hartford Healthcare, not just for the modeling, but for a variety of other clinical areas in our managing the stroke program, designing the surge capacity, designing the capacity and optimizing the OR models. My colleague, Dr. Stein, is going to go somewhat in detail, and and the professor will talk some more about his modeling and work he's doing with us at this time. With that, I'd like to introduce my colleague, Dr. Barry Stein, who's the Chief of Clinical Innovation for Hartford Healthcare. Dr. Stein.
Morning, everybody. I'm Dr. Barry Stein, Chief Clinical Innovation Officer for Hartford Healthcare. And Ajay, thank you for that introduction. This is about innovation happening right here at Hartford Healthcare in partnering with Dimitris Bertsimas, the Boeing Leader of Global Operations, Associate Dean of Business Analytics at MIT Sloan, as well as the Professor of Operations Research at MIT Sloan, but much more affectionately known to many of us as the Bruce Springsteen of analytics. This is about innovation fueled by years of collaboration between Professor Bertsimas and his very talented team of PhD and master's students. And over the years, Hartford Healthcare has been blessed to collaborate on many, many different very important initiatives applying very advanced analytics to help us take care of our patients. And this includes applying machine learning and artificial intelligence to help us predict outcomes for patients receiving chemotherapy, heart valve replacement, as well as stroke. We've also applied machine learning and optimization algorithms to help us manage capacity in our hospitals, as well as predict the length of stay of patients in the hospital. And we've also been very fortunate for us to have had Dimitri give us a 12-hour Analytics Edge for Healthcare course, which was attended by over 100 of our leaders across our organization from multiple disciplines, medical disciplines, as well as multiple functions in our organization, to teach us the most advanced methods in analytics and how they can transform healthcare. But as Ajay mentioned, the most important work currently is the work around managing COVID-19, helping us as well as the world plan better and more confidently in managing COVID-19. And that includes the Delphi Surge Predictor model that enabled our system to predict how many patients to expect, how many ventilators we would need, and how many ICU beds we would need. We've also worked on a risk mortality calculator that hopefully Dimitris will speak a little bit more about later. We've also worked on ventilator distribution optimization, as well as a risk calculator for patients that may have COVID-19. So all this work reflects a really deep friendship between Professor Dimitris Bertsimas and Hartford Healthcare, and a deep mutual commitment to impact the world so that people can live their healthiest lives. So with that said, I'd love to engage Dimitri on a few questions, and the first one of which I'd like to ask Dimitri is the following. When you look back on your surge prediction models, how accurate were they relative to what actually happened?
Hello, Barry. First of all, it's a pleasure to be with you today. Always a pleasure to talk to my Hartford hospital friends. So just to give you some examples, on April 3rd, we started the model in late March. So on April 3rd, we anticipated, and this is all publicly available in our website, covidanalytics.io. So on April 3rd, we made a prediction that in the end of May, there would be 1.4 million cases in the United States, 300,000 in Russia, and several other countries. And these predictions were remarkably accurate. In the U.S., as you know, at this time we have about more than 1.5 million. And in Russia, which at the time only had 30,000, it now has 318, very close with our 300,000 predictions. Overall, our predictions, we make predictions for all the states in the country and about 140 countries in the world, the error is about 5% from real life, which is, I would say, for the purpose of this model, quite strong.
Thanks, Dimitri. Can you provide us an update about all the other COVID-19 related research that's ongoing?
Yeah. First of all, let me tell you a bit about my group who's working there. We have a group of about 25 people, doctoral students, PhD students, and some of my colleagues at MIT. We have the initial model regarding epidemiology was the Delphi model. Differential equations lead to predictions on hospitalizations and infections. These are the acronym. So we have developed that, but then, which was appropriate at the time because the disease was, of course, increasing and then, thank God, is declining, at least in the United States overall. And we have started in early May an extension of the Delphi model to the case where we now have the effect of government policies. For example, suppose you continue the lockdown, suppose you open society, or you close schools and you don't allow mass gatherings. We have several policies. And for every policy instituted, together with at what point in time you institute this policy, we have predictions for all the 50 states in the United States and all about 140 countries of what we expect the new infections and deaths will be. So that's a significant effort which we update daily. In fact, our model is part of the CDC core models. I think they have 4. Ours is one of them. That's one area of attention. The other area of attention in which we have collaborated, as you know, with Hartford Hospital, together with other European hospitals, quite a few of them, is to create in our website a calculator for mortality and infection. The calculator of mortality is currently in use for several hospitals around the globe for when a patient arrives, which is COVID-19 positive, we calculate the severity of the disease for the patient based on laboratory data, demographics, comorbidities, and so forth, as it can be seen in the website. This is personalized information that the patients contribute. And then we calculate what is the probability that the patient might, in fact, die, which currently is being used for prioritizing ICUs and appropriately allocating capacity for these patients. And another calculator is for infection. So similarly, when a patient calls or comes to the hospital, we have pre-triaging, we know demographics, comorbidities, and afterwards we have laboratory tests, and we also calculate the probability the person is infected. That can be used also in the early stages prior to any test, or if somebody calls from home, to give appropriate advice given the information we have at the time. So these are two of the most significant developments that were developed after my last time. I think it was late April that I came to a similar event. This has new developments that happened during this period.
So thanks, Dimitri. That's incredibly impactful work, crossing multiple different areas in managing COVID-19. It sounds like the surge prediction models have worked out well, and now you've applied policy differences across multiple states, and it sounds like the public may find that interesting too, to have a look at. Can you let us know how you believe the public could benefit from using your website with all the different risk calculators as well as state policies?
Yeah. So let's give an example. So if you go to the website, fortunately I cannot show you because we are only a telephone connection, but let's say we use Texas as an example. So Texas, in the website, if you select, let's say, 3 policies, number 1, no restrictions, namely society opens up completely, lockdowns, which is an approximation of what's happening today, and an intermediate policy with you restrict non-essential businesses, and you also have travel restrictions in workplaces, that's intermediate between lockdown and no restrictions. You see a dramatic change in the predicted infections and deaths among these three policies. To give you an example, our predictions for end of September under lockdowns in Texas will be of the order, as far as infections are concerned, of the order of maybe 90,000 if under lockdowns. Under some restrictions, non-essential businesses and so forth, maybe 300,000, and completely opening the society about 600,000, a factor of 3 and a factor of 6, and a corresponding increase in the number of deaths. This is in Texas. But if you take, for example, the example of Connecticut, which I'm about to do right now, and you do exactly the same experiment, you see less dramatic changes. Obviously, you have more cases expected for no restrictions versus lockdowns, but instead of being a factor of 6 like it is in Texas, it is maybe a factor of 1.5. Namely, we expect around 44,000 cases in Connecticut under lockdowns, which we are not exactly at the moment, but under complete opening of society, we expect maybe 65,000. Still an increase, of course, but not of the same order of magnitude. And this takes into account the fact that in the state of Texas, versus the state of Connecticut, the opening and closing of policy, the opening of new policies, allowing society to open came, I would say, earlier, and lockdowns were perhaps more strict. So, in other words, the public, by taking into account by looking at the state they are interested in the United States, they can see comparative measures and the effect of policies. You can also experiment what happens if we impose measures in 4 weeks, in 6 weeks, and so forth. You can have a sense of what is happening around the country according to different policies. On the personalized level, for the calculators, one can calculate based on demographics, comorbidities, symptoms, the probability that you might be infected, number one, and if you are infected, how severe the disease will be to you. If you have lab tests, for example, oxygenation levels, hemoglobin A1C, BUN, and so forth, or even if you don't, you still can make estimates. So it can be even at the personal level or at the global level in terms of understanding what's happening in your state or your country.
Dimitri, thanks very much. I love that this is very much about analytics driving personalized medicine. And the last question I have for you is the following. There's a lot of talk about a second wave or wavelets. Given your modeling and your injection of state policy data and information, are you able to start to predict whether there will be a second wave, how big it'll be, and when it'll occur?
So, as I have mentioned, Barry, our policy predicts very different things for different states. So as a result, I contrasted Connecticut and Texas. In Texas, for example, if society opens, if the economy opens faster, or even at the speed that it's opening now, we most likely expect that there will be a significant increase in the number of infections. In Connecticut, unless unusual thing happens, for example, massive influx from infected people from out of state or from international places, we expect the likelihood would be less. Independent, of course, of what governments, state governments or federal governments do, a very important component is compliance, whether people utilize masks, the degree to which we utilize masks, avoid, exercise social distancing, even if measures are relaxed. It definitely would matter. But the website can give you a sense of when we expect, in which state it's more likely to have a potential second wave. Notice that our calculations are valid until mid-September, because after that, when the fall comes, it very much will depend on what policies governments apply, and also there's a significant effort with therapeutics and vaccines, as you know, the degree to which there is some success on that. I heard Ajay talking about a new drug and the hospital having 200 dosages for that. It has been found to be, giving some partial relief, and there have been positive trials so far. There's a lot of effort on that. So even if there is a second wave, with better therapeutics and hopefully some vaccines, we might cope with the disease. But I want to remind everybody that the most in the 1918 Spanish flu, 70% of the deaths came in the second wave. 20% of the deaths came in the first wave in the period like we have today, spring of 1918. But in the fall 1918 and winter of 1918, 1919, it was 70% of the deaths. So I would say, unfortunately, the threat is still exists. It's still significant, and we need to be fully aware of it and to take appropriate measures personally as well.
Thank you. So Dimitris, before we open up for questions from the media and others, just personally, on behalf of myself and Ajay, really very, very grateful for our continued partnership, having both been students of yours and now being the beneficiary of a very meaningful relationship to be able to make a real difference to many, many people in our state, across the country and across the globe, using your advanced analytics and algorithms. So thank you very, very much.
So Barry, it's a pleasure to work with you. The Hartford Hospital has been home for me and my team, and we are very excited and also grateful for the trust and the relation we have had. I mean it sincerely.
And thank you. From Jeff Flax all the way down, our CEO, we are very, very much appreciative and looking forward to many good things ahead. Thank you.
Well, welcome, Barry.
Thank you, Barry. Thank you, Dimitris. Before we open for questions, I want to remind the website Professor was mentioning is www.covidanalytics.io. We'll send you the link as well. We'll post on the Facebook as well. Going to open for any questions at this time?
This is Emily from The Current. I wanted to ask a little bit about the modeling. So one of the things that you were saying about the possibility of a second wave, if I understand correctly, you were saying that some states are not likely to see a second wave even if they reopen, and other states are likely to see a second wave because they reopen. So can you talk a little bit about the differences between states that are likely to see a second wave and states that aren't likely to see a second wave? What's the difference there?
The major difference is the following, is that, as you know, this disease is exponentially increasing. So if you open a state prematurely, before even it started to decline, or even if it started to decline but not so much, and then you open society, the transmission rate is such that the exponentiation of the transmission will significantly increase. On the other hand, this is, for example, in Texas. If, on the other hand, as it has been the case, and Ajay mentioned that the number of patients at the hospital went down by almost a factor of 3 or 4. Namely, we are now at a significant level, a decrease of a significant level of new infections. Then this exponentiality that occurs is not as threatening. For this to again be a very significant increase, what is called the second wave, it has to be the case that you are in an environment that the disease increases beyond. A key parameter is a parameter of what is called R0, namely how many, on average, how many a person can infect. If it's more than 1, it explodes. If it's less than 1, it dies or it decreases. There's less probability of a significant second wave. Timing is critical. And I would say if you open the country or the state prematurely, then you are a victim of the exponentiation. If you apply appropriate measures, you have now the disease far in control, you are less threatened by that. Am I making sense, first of all?
Yes, that makes sense. Thank you.
Yeah.
Hi, good morning. It's Bridget at the Republican American. If we just look at the national statistic, we have just passed this benchmark of 100,000 deaths. Regardless of the second wave, where do you think we're going with that national statistic?
Yeah, this will very much depend on what policies the governments apply, in particular in states that are in greater danger. What I observe in the country is that more or less all states are not in lockdown anymore. They have taken some measures of relaxation, some more than others, and some never even have lockdowns. So my conservative estimate, given that we have passed 100,000, by the end of the summer we might see of the order of 150,000, 50% increase, which can of course be higher or lower depending on how aggressively we open the country, especially in areas that are in high threat for a second wave. And I mentioned also several of the states in the southern United States. So unfortunately, just to take a minute to reflect, 100,000 deaths is a very significant number. It's more than the number of deaths the United States had from both the Korean and the Vietnam War together. So that's a very sober moment for the country.
Thank you. Dimitris, Lisa Carberg at News 8. Can you please talk about a second wave for Connecticut?
Second wave of Connecticut. As I have indicated, this assumes we also have, assuming we have some reasonable measures, namely we don't open the society completely, I don't expect, in Connecticut anyway, a very significant second wave. If, on the other hand, we allow people from abroad, for example, let's say from Latin America, which is the epicenter of the disease at the moment, coming to the United States and bring further infections and so forth, without quarantines, without, if we are somewhat careless on this, this could become also terrible. But assuming reasonable policies, namely being careful on not allowing people from countries that are very infected coming to the U.S., not completely opening everything, I think this is unlikely in Connecticut. I don't believe this is the case for many other states, but Connecticut, I would say it is. It will still increase, but it is at a size that it is completely unmanageable. Am I making sense, Lisa?
Yes, thank you.
Of course.
I'd like to piggyback on Dimitris's comment. From our perspective, we expect some rise in the cases in fall and the winter time, without a doubt, in Connecticut, at least in my opinion. The complexity is going to be that we're going to be hit by flu season and the COVID at the same time. So effect on society and the hospitals is going to be somewhat interesting to manage at that time. And that's one of the reasons why the measures we put together right now of creating a separate triage mechanism, we're going to sustain them for a long time, creating a screening process, expanding a testing capability, creating a process of making sure that our essential surgeries and procedures are done safely in the organization. Our employees are tested appropriately, antibody research, all these things are going to help us prepare better for the fall and the winter. And at least from the hospital perspective, hospital healthcare system perspective, our focus is that we continue to manage the summer With the low level of activity we're going to continue to see of the COVID in Connecticut, but position us in such a way with adequate supply, the safety precautions, the checklist we've been putting together, the triage mechanism, the employee testing, the antibody testing, and other measure, isolation and contact tracing, and many other things we have began doing and we've done very well, in at least in Hartford Healthcare, to position us for the fall and the winter. And I'm confident at this time that the Hartford Healthcare in a position right now, we are thinking about our winter and the fall planning. We're thinking about how we're going to make sure that the healthcare system is there to support the community need. And the commitment to the community we had with the testing, which we started in April, and we've done so many mobile testing, is a testament of that. We want to make sure we understand the prevalence of the disease at this time. And over the time, we will see the conversion, and we'll be better prepared at the time. So I want to reassure that at least the community in Connecticut, the systems like ours are working to make sure we're not thinking about the short term and goal for today, but it's a long term. Our therapeutic capability with the convalescent plasma, remdesivir, or other things which are out in horizon will help us. But the vaccine is still a little far away. We still don't know whether the vaccine, if it's going to be available, is going to be effective, number one. But when it gets become available, it'll probably would be early next year. So we have some time to go. The fight is still not over yet. We're still not out of the woods. We're going to have to continue to watch our physical distancing, our the things we've been talking about, the hand hygiene, the sanitary measures. We need to continue to focus on that. And that is how we're going to help each other to manage this over the next several months to come.
This is Emily from The Current. I just have a quick follow-up for Dimitris, if that's all right. I'm looking at the website, and if I go to the case predictions, not the policy evaluation page, does the case predictions page take into account a state's current policies as well?
It does, but our view is that this model will be appropriate until mid-June. After mid-June, and we'll make appropriate changes, but the right place to be is under policies. So at the moment, I would say the results are accurate, and it will be accurate until mid-June. But as you know, it's already end of May. So in the next 2 or 3 weeks, it will be okay. But after that, the right thing to go under policies, because policies are being relaxed around the country, some places more than others.
And then the policy evaluation page, that's valid until mid-September, you said?
Mid-September, I would say.
Okay.
The mathematics are valid beyond, but then we have to start predicting what government will do in the middle of the summer, which is, as you know, very difficult to do.
Right, okay, thank you.
Of course.
Tina, you have some questions on Facebook?
Yes, we do. Which test do you recommend for someone to have COVID-19 or the antibody test?
Well, I think there are two different types of tests, PCR and antibody testing. PCR is one detects whether you have COVID-19 or not. Antibody test detects whether you had COVID-19. I recommend people to get, if they're concerned about, get a PCR testing, especially when you have symptoms like cough, fever, or you're recovering from some of those things. So understand whether you have active disease or not. But if you're out of the woods and looks like you've never had, or you're curious about whether you had any exposure to COVID-19, antibody testing will help. So depending what question you're trying to answer, you can choose whichever the test you like. I suggest if you're symptomatic and if you're living with somebody who's vulnerable, if you have any concerns about immunosuppressed or something like that, PCR testing to evaluate whether you have testing would be helpful.
We have a question for Dimitri. Does he think that Connecticut opened too early or appropriately?
I would say appropriately, or reasonably appropriately. Most importantly, it closed. I mean, obviously earlier would have been even better, but at a reasonable time. So far, I would say appropriately.
I'm just going to comment on that. It's not so much about whether Connecticut opened appropriately or not. It is about the community, how they actually adhere to the principle of social distancing and physical distancing, wearing the mask all the times, making sure we remain clean, we don't go out to the beach parties and things like that. I think that's important. I think the governor, in my opinion, has done a good job of measuring and looking at all possible angles. It's up to us, all the community member, to make sure that the decisions we make are going to help us over the time. That's it? Very good. Well, thank you very much for everybody's time. I, again, advise everybody to look at the website and learn about where we are. Continue to seek out testing site with Hartford Healthcare put together, 9 permanent and over 40-something testing so far and 15 to do this week. We're going to continue to work on that. And I do want to thank Dimitris for his collaboration and partnership with MIT. Having a Hartford Healthcare and a premier institute like MIT to be able to work on some really complex and some of the challenges we've never tackled before. It's a real privilege. It's for us, for our community. It's a game changer, in my opinion, for our community to have that kind of level of expertise and access for us to advise and plan and think about how we deliver the medicine. And this is what's going to change how we practice medicine, how we support our community need, and how we keep everybody healthy. And I recognize Dr. Stein for his effort continuously, who has really worked hard to develop this relationship, and a professor and many of his very brilliant scientists, and I've had a pleasure to meet and work with, have been truly friends of Hartford Healthcare in Connecticut. Thank you.
Thank you also, Ajay.
Thank you.